Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. And we are very truly appreciate the presence of esteemed doctors and participants who have joined us for this webinar. And let me tell you the topic for today's webinar that is very much important. That is decoding the signal preventing stillbirth with CTG. Stillbirth continues to be a major concern in obstetric and timely intervention can make all the differences. CTG is a vital tool that helps us identify early sign of fetal distress, guiding us to make the right medical decision and ultimately saving lives. This discussion will help us to gain practical insights and reinforce our commitment to safer pregnancies and better outcome. So, as we know that this topic is important, so we need someone who is very much into this. Without any further delay, I would like to invite the host for this webinar, and none other than Dr. Sharda Jain, ma'am. And let me share some of the achievement of ma'am. Ma'am is a senior consultant obstetric and gynecology and director of Life Care Center and Life Care IVF, an expert in ethical committee of NMC, secretary general of DGF, and founder and chairman of the North India Gynecologist Forum. Dr. Sharda ma'am has been guiding a light in the field of women's health, and we are privileged to have you, ma'am, for this important discussion. Ma'am, the stage is yours. You can proceed from here. Over to you, ma'am.
Thank you so much. Uh, Great good evening to all of you who are watching us. And this is another opportunity, and my great sincere thanks to Med Talks that today we are going to talk on a topic of profound importance. He has already said decoding the signals preventing the stillbirth with CTG. As you all know, as far as country's overall stillbirth rate is concerned, it is 14 per thousand as per the Stillbirth Society of India, who had a conference in 2024. And at the same time, it's my privilege to say that Kerala has lowest rate of stillbirth as per the country is concerned. It is 1.5 per thousand. I'm also failing to say that in Hyderabad there is a hospital which has 10,000 deliveries per year. They have a stillbirth rate of 2.5 per thousand. I think, to delve on this topic, we have great experts today. And I welcome uh, Dr. Arun Kumaran. He's a distinguished British Sri Lankan gynecologist, great teacher, great academician. And he has held the position of president of RCOG for 3 years. He had been a FIGO president for 3 years. And I think, we have Dr. Asmita Rathore. Asmita Rathore herself is a decorated gynecologist of Delhi. She had been a past chief of Maulana Azad Medical College. She had been a medical director of GTB Hospital, and presently she is in Manipal Hospital as a senior consultant. We have, before I ask Dr. Asmita to introduce Sir properly, I will introduce Dr. Anita Kaul. Is also a great, renowned family medicine expert in the city. She is heading the Apollo Center of Family Medicine and Fetal Therapy. She's also the international postgraduate program director for RCOG. She's also the postgraduate director for fetal medicine society, which is based in Barcelona. So over to you, Dr. Asmita. Asmita.
Yeah, thank you, ma'am, and good evening to everyone. Uh, Today, my job is now to introduce today's topic and Professor. Uh, Faraz, can I have my slides? Yeah. So the topic Faraz has already introduced, that is decoding the signals, preventing the stillbirths with CTG. I'll just give a brief overview of the Indian scenario. We all know tragedy of stillbirth is not only an emotional and psychological distress for the family, but it also increases the healthcare system demands in terms of resources, special care interventions, and is also a reason for maximum number of litigations obstetrician face. The stillbirth rate in India, Faraz, am I not on slideshow?
You are, ma'am. It's perfect.
I think I'm not on slideshow.
Ma'am, it is full screen to us, ma'am. You can proceed, ma'am. Like, it is full screen.
Should I carry on?
Yes, ma'am. Yes, ma'am. Perfect.
So the stillbirth rate in India is one of the highest in the world. And as per the World Bank data in 2023, it's 11.8. And as per NFH's data, it's 9.7. These figures have to be taken with a pinch of salt, keeping in mind the reporting gaps in this country in view of different gestational age cutoffs to define stillbirths, different definitions used by different reporting systems like National Family Health Survey, and obviously underreporting. Moreover, there is a wide variations in stillbirth rates in different states of the country. Stillbirth rates are the indicator of perinatal healthcare services, and UN has included stillbirth in every newborn action plan 2020. The India Newborn Action Plan has a goal of achieving less than 10 stillbirths per thousand by year 2020 and ending the preventable stillbirths. We all know the causes of stillbirth, and the Lancet 23 has listed these causes, which include maternal, fetal, placental, unexplained, and the hypoxic peripartum events. And about half of the stillbirths and early neonatal deaths occur during labor, which means that the preventing stillbirth strategies need an multi-level and multi-pronged intervention. And fetal surveillance, both antepartum and intrapartum, is an important intervention to achieve this target. The fetal heart rate monitoring remains the key intervention for a fetal surveillance, both in terms of intermittent auscultation and CTG or continuous electronic monitoring. Now, continuous electronic monitoring or CTG is a standard of care in all high risk pregnancies. It has advantages of high sensitivity, continuous and objective record, but the limitations of high false positive rate, increasing cesarean section rates for fetal distress, and significant intra and interpersonal variation in interpretation. And for this particular problem of variation in interpretation, it's recommended that we should use the uniform classification everywhere. Now, the conventional classification of a CTG trace combines fetal heart features in terms of rate, variability, deceleration, and acceleration. And this trace has been now classified on the basis of the combination of these features on either normal, suspicious, pathological, or category 1, 2, 3. However, there is a paradigm shift in 2018 in the basis of CTG trace classification from arbitrary FHR based features to the one based on understanding of fetal pathophysiology, recognition of different types of fetal hypoxia, and features of compensation and decompensation on the CTG trace. Thus, physiological interpretation of a CTG, which is updated in 2024, is associated with improvement in maternal perinatal outcomes, and it also aims at individualizing the care in the context of overall clinical picture and risk factors in an individual case. And to speak on this topic, we have an towering personality, Sir Arul Kumaran. He is the Professor Emeritus of Obs-Gynae at St. George's University of London, where he was head of the department for 13 years. He's foundation professor at University of Nicosia, visiting professor at Institute of Global Health Innovation, Imperial College. He has held the prestigious post of a past president of FIGO, British Medical Association, and RCOG. He has to his credits 38 books and nearly 325 indexed articles. He has been awarded national honors in UK as a knowledge bachelor in recognition of services to medicine by late Queen of England, then Sri Lanka also, and in Cyprus. Apart from being having a great academician, he has been a great support to many of the students who travel to UK for training and was my mentor also. Thank you, Professor. Over to you for the today's talk on decoding the signals, preventing stillbirths with CTG, based on physiological interpretation of cardiotopograph.
Thank you. Thank you very much. It's my great pleasure. I would like to pay my respect to Dr. Sharda Jain, Asmitha Rathu, who has actually spent a lot of time and effort in organizing this seminar, and Dr. Anita Cole, who will be coordinating the questions and answers in the comment session. So I might just start with my presentation and go through very slowly. And if there are any questions, you can put it on the chat box and we can take it from there. So this is a report which came in from the Royal College of Obstetricians. For 4 years, they were also concerned, and it's continuing to concern, the number of stillbirths and early neonatal deaths, as well as catastrophic brain injury following birth asphyxia. As you could see the figures from 2018, there were 651,587 births, and of those, 11% was intrapartum stillbirths. That is altogether 121 babies, or 11%. 14% were really early neonatal death within 48 hours. That's related to birth asphyxia. And 75% had hypoxic ischemic encephalopathy, and as a result, many of them ended in cerebral palsy. So it's not a simple problem. It is a serious problem, even in the developed country, despite advances in equipment and technology. Now, this was later categorized into substandard care nationwide. That means where have we gone wrong? And in 2015 to 2018, as you could see, more than 70% of cases they thought there was substandard care. And they could have improved care and changed the outcome of the babies. And that was mainly due to CTG interpretation difficulties, risk recognition. They don't recognize that if the baby is small, like growth restriction or thick meconium, there'll be more problems. And then the individual human factors, reading and the education aspect, and also team working. So these are a number of factors which cause that. And as a result, 2.3 billion pounds were paid for this compensation. That means about 3,500 pounds is kept aside every time a mother comes into labor in case something goes wrong. The compensation is about 10 to 15 million, but on an average for each child, we are spending only on litigation 3,500. So poor CTG interpretation contributes, but it's not the only factor which causes these stillbirths and problems. So in a summary, and I must admit that it is not one factor, but multiple factors operate in a single case. So same factor case will have CTG interpretation with risk recognition failure, with poor team working, and it's a multiplication of factors which gives rise to the problem. Now, in summary, we can identify the factors which gave rise to the problem. Inability seems to be the number one factor, poor pattern recognition without understanding the pathophysiology that causes the CTG changes. Secondly, not identifying the back risk factor which can push the baby from trippies so that suddenly things can change. So risk management is quite important to find out the risk underlying the baby. Poor communication, individual human factors, and the failure of education and training. So I salute the team in New Delhi for organizing this meeting, because education and training issues is quite an important one. Now, people argue that the intrapartum pure deaths or hypoxia is only about 5%, but 25% are really due to antenatal and intrapartum risk factors. Roughly about 30% are due to these issues. So in other words, risk factors are something very important. And if it's a high risk case, like IU growth restriction or meconium or an oxytocin or previous scar, then they should be on a continuous monitoring so that they can identify the risk early and manage them. It says that steady for 30%, so 70% are due to other factors. That means congenital malformation or infection or unrecognized growth restriction and so on and so forth. Now, coming to risk recognition, I would ask you to think of 6 factors, which is very easy to count on the fingers. Performance could be improved by paying attention to these risk factors. One is preterm, because they are more vulnerable. If they are hypoxia, they get hyaline membrane disease, RDS, and run into trouble. Post-term, because their reserves are much less, and if they have CTG changes, then acidosis buildups much faster. Intrauterine growth restriction, depending on the size of the baby, the size of the placenta will be small, and therefore with decelerations, acidosis builds up faster. Intrauterine infection has a synergistic effect with the baby. Hypoxia, because the brain damage is much greater if it is an infected baby who gets asphyxiated. Thick meconium with scanty fluid. So thick meconium can be passage due to maturity, but if it is scanty fluid, that means it is a hypoxic event, reduce the renal perfusion and therefore little fluid. And antepartum bleeding, mainly some form of abruption which can suddenly blow up. Now, in a single baby, there can be two factors: a preterm baby, preterm birth triggered by intrauterine infection. So there will be additive factors, and post-term with thick meconium and abnormal trace, we had to intervene early. Now, iatrogenically, we can introduce fetal compromise. Injudicious use of oxytocin, as we know, the CTG pattern recognition by NICE includes hyperstimulation of the uterus. If there are more than 5 contractions in a period of every 10 minutes for a period of 30 minutes, then it is considered abnormal. Or more than 6 contractions in 10 minutes for more than 20 minutes. That can be because of the use of oxytocin or misuse of prostaglandin. And oxytocin, the things to remember are 2 issues. One is the contractility of the uterus increases with the rate of cervical dilatation. So with the same dose, she's contracting 4 and 5 at 5 centimeters. At 7 centimeters, she'll be contracting 5 or 6 in 10. So it becomes sensitive, so we have to tail it down. Second is towards the late first stage and second stage, there is a natural stimulation called the Ferguson reflex due to the compression of the cervix and the vagina due to the head coming down, and that can increase the oxytocin infusion. Hypothalamo uterine reflex, which is called the Ferguson reflex, which causes more contractions. The next iatrogenic mistake we make is when there is an epidural in the early labor, it's not a problem, but late first stage and second stage, the head is in the pelvis, and the head reduces the blood flow to the uterus by pressing on the uterine vessels, which comes the floor of the pelvis. And every contraction, that flow of the blood is reduced. And if there is an abnormal CTG, and when you're going to give an epidural, and if you keep her, ask her to bend or lie on the lateral side and flex her body to give the epidural, that can give rise to compromise. So you have to keep monitoring. The third is difficult instrumental delivery, malposition. We have to bring about the baby with a traction on the traction point or the axis point, where it is 3 centimeters in front of the vertex. The cup, if it is vacuum, has to be placed in the right place. If you put it on a paramedian deflexing position, then you pull a large diameter of the head, and that baby gets compromised due to compression of the head. Malpresentation like breech, if you don't deliver properly, then that can get asphyxiated at the last moment. Or macrosomia, if you don't learn the mechanics and how to deliver a shoulder dystocia, that can cause asphyxia. The other events which can cause problems are sentinel events in labor, like cord prolapse, abruptions, cord adhesions. These have to be recognized clinically. And finally, suspicious abnormal admission test. Not necessarily a CTG, but even intermittent auscultation. And the first question you would ask is, how are you? And the mother will say, I'm fine. Secondly, you have to ask, how is the baby? Is the baby moving? If the baby is not moving, then you have to listen to the baseline rate and feel for the baby's movement, and tell the mother to tell you when the baby is kicking, and when you also perceive, you write on the notes, mother and I felt the fetal movements, and at that time, this was the heart rate. And that heart rate with the kicking of the baby should be at least 15 beats above the baseline heart rate you have listened to before. Now, of these iatrogenic risk factors, this can coexist with the naturally existing risk factors like prolonged pregnancy or post-term pregnancy with thick meconium, then doesn't progress, then you put on oxytocin, and finally end up in a forced delivery. That's a bad combination. So combination of factors are not very good. Now, these factors are not plucked from the air. They are from a number of large studies. Like, for the example, the chance of a low Apgar score at 5 minutes being less than 7 is much greater if there is growth restriction, previous cesarean, There is fetal growth restriction, thick meconium, and so on, or macrosomic baby. So this is from series after series, which tells the high risk factors. Now I go to the NICE classification, which is built on pathophysiology, but it is not explained properly. So I'm going to build it by saying decoding the features we find. One is the baseline fetal heart rate, and second is baseline variability, and third is decelerations. Fourth is contractions, and fifth is accelerations, although we put the accelerations along with the CTG on the baseline heart rate features. Now, we all know the heart rate is determined by the sinoatrial node in the right atrium, and the heart muscle is a syncytium, where the impulse is created from the sinoatrial node diffuses, and the right and left atrium contract, and the nerve impulse goes through the bundle of his to the ventricular, top of the interventricular septum, and then the ventricles contract subsequently. Now, this heart rate by the sinoatrial node is faster than by another pacemaker called the AV node on the top of the interventricular septum. Therefore, the SA node overrides the AV node unless there is a heart block due to fibrosis of the bundle of His due to systemic lupus erythematosus or other conditions like that. Now, the SA node itself is controlled by the parasympathetic and the sympathetic nerve. And the parasympathetic, it comes through the vagus nerve, and if you stimulate it, this heart rate slows down. And if it is sympathetic, then the heart rate increases. Sympathetic is a direct innervation, like somebody trying to point a gun at you, heart rate will go up. Similarly, if there's any excitation like a big sound noise, the baby's heart rate tends to go up. So that is the autonomic nervous system, and we have no control over heart rate. So it varies from minute to minute and second to second, and that gives rise to the baseline variability. The sinoatrial node to the baseline rate, and the autonomic nervous system to the baseline variability. Now, this is further controlled by changes which is coming in with contractions. That is, the pressure of the baby's system, arterial system, can drop or increase, and that is perceived by the baroreceptors in the carotid and aortic. And the chemoreceptors will pick up increase in carbon dioxide or decrease in oxygen. And if there's a decrease in oxygen or increase in carbon dioxide, the heart rate will go up. And same with baroreceptor mechanism. But if it is more than a certain amount of loss of oxygen, then it can decelerate, or increase in carbon dioxide can cause deceleration. Now, this has been studied in many animal experiments, and this diagram looks complex, but we have already discussed there is an autonomous pacemaker, which is the SA node, which produces the heart rate. And on the right side, you can say the sympathetic, parasympathetic modulates the heart rate, and then the chemoreceptors or baroreceptors. But what we depend mostly during labor is the release of catecholamine due to hypoxic stress, and that is the release of adrenaline, noradrenaline, that affects the heart rate. So whenever there is a cord compression, the deceleration starts due to chemo or baroreceptor mechanism. And when there is hypoxia, there is an increase in the baseline heart rate gradually due to the catecholamine release. So you get, and the accelerations tends to disappear because when the baby gets hypoxic, the accelerations are due to the somatic nervous system, the baby don't move, and there's absence of accelerations. So keeping that as a background physiology, we look at the NICE guidelines. The NICE guidelines talks about baseline rate, variability, accelerations, and decelerations. And this is to do with the baseline fetal heart rate. And this is same with the FIGO NICE, the Swedish American classification. 110 to 160 beats per minute is normal, which is called as white. And if the heart rate is 20 beats per minute for more than at the start of labor or beyond 180 or below 100, then it is called abnormal, and it is called red. Over 160 is red, but if it is over 180, it is significant. So you have to distinguish the fetal heart rate from maternal heart rate, because sometimes the transducer can pick up the maternal heart rate, especially in the second stage of labor when the head goes down. So you have to be careful. And for purposes of interpretation and perceived action below 100 or over 160, and especially if it is over 180. Now, if it is combined with reduced variability and decelerations, it's a greater problem. So more than one feature will be a greater problem. Accelerations are due to the somatic nervous system. So when the baby moves, there is an acceleration. That means there's a well-oxygenated baby. Before the autonomic nervous system gets into trouble, the somatic nervous system doesn't work. So the babies don't move when there is hypoxia, when there's infection, when there's not cerebral hemorrhage. So absence of accelerations are of concern. But it doesn't say it is hypoxia. It could be other factors as well. And if we take this trace as an example, the baseline rate here is 140. There are accelerations, and if you follow them closely, they correspond with the fetal movements. Every time the baby moves, there's an acceleration. And if there are two such accelerations in a 15 minutes window, an acceleration defined by 15 beats above the baseline for 15 seconds, the paper speed is 1 centimeter here. So it is accelerating for 30 seconds for more than 15 beats. Up to 20 beats, it is accelerating here. So that is called reactive. Reactive means reacting to the fetal movements. It's an English terminology. And that means the baby's autonomic nervous system is well, and there is no hypoxia. Now, when the acceleration is present, most of the time, the variability, which is the bandwidth in a centimeter trace, the topmost and the bottommost, and the bandwidth is 5 to 25. If it is less than 5, the baby might be sleeping, or there might be hypoxia. We have to distinguish that. And if it is more than 25 saltatory, that means the autonomic nervous system is in overdrive, and it could be running into hypoxia. So here you can see the baseline rate, the variability is normal, the baseline is normal, accelerations. And fortunately, there are no decelerations in response to contraction. So there is no head compression, reduced retroplacental pool of blood, which will give rise to late, or cord compression, giving rise to variable deceleration. So there are no such decelerations, which means this baby is in good health. I call it the baby is running, tossing the ball up and down, and smiling. It's good variability. It's a good sign. And fetal movements, as you can see in the early labor, you can get it. And there are a number of studies by Fred Kubli in Germany, Richard Wall in America, Richard Beard in UK, where shown if the accelerations are present, not a single baby is acidotic. That's a good sign. But if it is absent, it doesn't mean the baby is anything wrong. On the other hand, if there's complicated baseline tachycardia, which means tachycardia with reduced variability and deceleration, 65% might be acidotic. But that's a function of time. The more you wait, the greater the acidosis. And it'll show signs where the decelerations gradually increase in depth and time, and the interdeceleration interval gets shortened, and the baseline rate goes up. So as that features evolve, then more babies get hypoxic. Another important feature in CTG interpretation is cycling. Like reactivity is an important feature. Cycling means the mature baby will have period of accelerations and good variability followed by a period of sleep. And as you could see here, this is a CTG trace from the beginning of labor to the end of labor. I cut and pasted it. So this is an active, this is a quiet. And these quiet periods tend to be the same amount of time in any baby, like we fixing an alarm clock at 12 o'clock, getting up at 6. It's tend to be like that. And if you're worried that it is going for a longer time, say, for example, if you give pethidine, it might go for a longer time. But with the contractions, if there are no decelerations, then you don't have to worry, because deceleration, the hypoxia doesn't develop unless there is a mechanism, either cord compression or reduced retroplacental pool of blood with late deceleration. So if the baseline period doesn't show up accelerations quickly, it goes on for some time, you have to think, is it due to pethidine, it is due to infection, or it is sleeping? And if there are no deceleration, then you can be reassured, probably there's nothing to worry. Now, baseline variability, as I mentioned, 5 to 25 is normal. Below 5 is not very good. For more than 50 minutes, and more than 25 for more than 10 minutes. So let us look at this autonomic activity, which gives rise to baseline variability. Now, I mentioned about cycling, so it could be up to 50 minutes because of the cycling phenomenon. but increase in 25 or more, then it is better to have a second person to look at it and see, is there anything which we are missing, like rise in baseline rate and deceleration? Because if there is a rise in baseline rate with the saltatory pattern, or deceleration with saltatory, that might incriminate the possibility of hypoxia. Now, we don't call it beat to beat variation because 3 to 5 beats are merged into one dot. So we have to use the terminology baseline variability. You take the lowest point of swinging to the topmost point in 1 centimeter segment and read it. And you read it at the best point, not when it has gone to sleep, but in between the accelerations if there is a baseline. So that is due to sympathetic going up and parasympathetic bringing it down. And the baseline rate is a little bit higher before 34 weeks in the preterm because the parasympathetic hasn't developed so well. Now, the NICE classification has saltatory more than 25, normal 5 to 25, and reduced is less than 5. But the Swedish classification has called a silent pattern, 0 to 3, and some use it 0 to 2, if it is like a flat baseline. That means the brain is virtually not functioning, and there must be a serious problem or hypoxia, infection, or something else. But for all intention purposes, we can stick to NICE and call 3 to 5 or less than 5. And if it is reduced to less than 3 or 2, then you have to be careful. And if it is less than 2 or hardly any variability for 10 minutes, that's seriously wrong. And you have to look out for other features like bleeding, thick meconium, absent fetal movements, and take action. The problem with reduced variability can be physiological, can be due to hypoxia, medications, prematurity, tachycardia. The heart rate is more than 180. The machine is unable to produce good variability. Cerebral hemorrhage, fetal malformations, and arrhythmia, as well as anesthesia. And if it is less than 2 beats, then it is usually due to hypoxia, cerebral hemorrhage, anesthesia, some serious problem is going on. And you have to pay attention to a straight line. Saltatory shows like this, and this is just an example. They were giving an epidural, didn't monitor the fetus. As soon as they started monitoring, there is saltatory pattern going for more than 10 minutes. And you can see there is subtle deceleration. That's a serious problem. And nothing was done. So it gradually becomes bradycardic and the heart rate drops. So they tried to do a forceps, but it was OP, but high up. So they had to do an immediate section, and it was early neonatal death. So saltatory has to be looked very carefully and related to what is a progress in terms of labor. Now, coming to deceleration, which causes a lot of confusion as to early, variable, late, and there have been some recent evidence about what happens. And the NICE classifies as repetitive and non-repetitive. If it is occurring for more than 50% of the time, then it is called repetitive. And then they say there is absence of shouldering or there is absence of variability between deceleration. That might be not a good sign, and it might lead to hypoxia. Now, I can reassure you that we can look at it in a very simpler way. But before we go to that, we can say repetitive variable deceleration with any concerning characteristics for more than 30 minutes, or repetitive late deceleration for more than 30 minutes, or acute bradycardia, or single pronged deceleration lasting for more than 3 minutes. You call it red. It doesn't mean that you have to deliver, but you have to take action if it doesn't improve, and one has to be concerned. And we take that period for 30 minutes if it is repetitive. That means within a very short period, more than 50% of the time, these decelerations occur. So we'll just do a simple basic idea about decelerations. Whenever you see the pattern, you draw a vertical line from the beginning of the contraction, and you draw another vertical line at the end of the contractions. If the deceleration falls between these two lines, that is a mirror image of the contraction because you're drawing one at the beginning and the end. These are early decelerations, and that's due to head compression. And the variability is maintained, and the baseline rate doesn't go up or down, it remains the same. And the contraction patterns are not hyper more than 5 or 6 in 10 minutes, so this baby is going to do quite well. Now, if you look at this trace, it looks almost similar to that. But if I draw the vertical line from the beginning and the end, the deceleration comes after the end, backs to the baseline after the second line. So first line, second line, and as you could see, the deceleration is afterward. These are late decelerations. The variable decelerations, the deceleration starts with the first line and continues, and as time goes on, goes beyond the second line. Whereas late decelerations start after the contraction has started. So if it starts with the contraction, it is variable and due to cord compression. But if it is after the contraction started, they are late. But again, the two lines will help you, because any deceleration, whether it's variable or late, if the deceleration goes beyond the second line and comes back, then that's a problem, because that is usually due to myocardial hypoxemia. And sooner or later, the decelerations will get more and more prolonged, and the interdeceleration interval becomes less, and heart rate starts going up, and the baseline variability comes down. So these are no concerning features, because there's shouldering, there's variability, there is a precipitous fall on the rise, and this is most likely due to, we think it is due to chemo, according to the recent research, can be due to Barrow as well. Now, with concerning features means if I draw a line at the beginning, at the end, the decelerations start coming at the beginning, but tends to go even beyond that line. And as time goes on, it goes beyond that line. So this is again repetitive, coming every contraction. So it'll be more than 50%. So this is concerning feature. So these are repetitive variable decelerations with a complicated feature of late recovery. Now, coming to the basics, there have been a lot of confusion about whether these are due to chemoreceptor reflex or whether they are due to baroreceptor reflex. So a team from New Zealand did some work, and what they did was they did vacotomize the lamb inside the sheep, and so that they can vacotomy to disorganize the peripheral chemoreceptors, and repeated brief umbilical cord compressions. The baby gets hypoxemia and then hypoxia. Hypoxemia is lack of oxygen in the blood, hypoxia, lack of oxygen in the tissue. So if they keep on doing that, then it becomes a cardiovascular adaptation because of the reduction in the blood pressure. And as a result, it takes time for the heart rate to come back to normal. So initially, it'll be, this is the fetal heart rate. As you could see, this is the vagotomized. It doesn't show any change because there is no chemoreceptor passed on through the vagus to cause any problems. And this is due to the peripheral chemoreceptor. Some action takes place. And this side is talking about the mean arterial pressure, and the mean arterial pressure tends to go with hypoxia. And as the progression carries on, the peripheral chemoreceptor reflex starts the deceleration. Then the hypoxia causes myocardial hypoxia and causes the heart rate to return to baseline a little bit later. So the initial chemoreceptor-induced decelerations, but prolongation of decelerations beyond the end of the contraction is to the drop in blood pressure and increase in the acidosis causing myocardial hypoxia. So in other words, a deceleration, longer it takes, it is not a good thing, and we have to take some intervention. So these were the key points in the article. Brief repeated hypoxemia during labor can trigger fetal heart rate deceleration by the peripheral reflex or myocardial hypoxia. But how this balance changes with fetal compromise is unknown. Reflex-controlled fetal heart rate was disabled by vagotomy to unmask effects of myocardial hypoxia and chronically instrumented fetal sheep. Fetuses were then subjected to repeat brief hypoxemia consistent with rates of uterine contraction during labor. We show that peripheral chemoreflex controls brief deceleration in their entirety at a time when fetus were able to maintain normal or increased blood pressure. But peripheral chemoreflectors still initiated the deceleration even after the onset of evolving hypoxic acidemia, but myocardial hypoxia made the increasing contribution to sustain and deepen the deceleration. So that is the crux of the matter. That is, if you look at this in a diagrammatic fashion, I mentioned about the line at the beginning, at the end. So this deceleration, they are variable, but these are due to chemoreceptor reflex. And as time goes on, initially it is between the two vertical lines, but as time goes on, the deceleration falls outside this line. That means this element is going to get worsened with incidence of myocardial hypoxia. And as a result, the catecholamine surge, the baseline rate is going up and up and up. It goes up further. And the depth and duration of the deceleration goes. But the most important factor is also interdeceleration interval. Because it takes a longer time, the interdeceleration interval where the baby can get normal amount of blood supply gets reduced. So it's like a baby swimming in the swimming pool from 0 to 100 meter mark. If it dips only a short time, then remains in the surface for a longer time before it dips again, then it can wash out the carbon dioxide, get the oxygen, it'll be back. But if it dips for a longer time and comes to the surface for a shorter time, then it is going to get breathless sooner and get hypoxia and acidosis. So you can see the features of rise in baseline rate, increase in depth and duration of the deceleration, reduction of the interdeceleration interval. So the question is whether we should incorporate the interdeceleration interval into classification system, and that is coming very soon, proposed by various people. But for the time being, for you as a practical obstetrician, you have to think not only of the depth and duration of the deceleration increasing, rise in baseline rate, and reduction in baseline variability, but think of the interdeceleration interval, which indicates that the baby is likely to get hypoxic. So these are late deceleration, as I mentioned. If you draw two lines, then these will be coming on later, or the onset of the deceleration is after the nadir of the nadir is later than the acme and the contraction. So there's a time difference of 20 seconds between the top and the bottom here, indicating they are late decelerations. Now, in addition to that, if the baseline variability is absent, then probably it's a pre-existing or long-standing hypoxia. And if you draw the line here, again, the deceleration afterwards, but there's nothing in the baseline. So the baby is affected by infection, cerebral hemorrhage, congenital malformation, or hypoxemia. But the fact that decelerations are present indicates it's hypoxemia, because if it is due to hemorrhage, it'll be brain hemorrhage, it'll be a straight line. Infection, it'll be a straight line. Or infection and hypoxemia or hypoxia, then you'll get that deceleration. So if decelerations are present, then hypoxia is a constitution of the deceleration. Now, additional features which defined as abnormal is the bradycardia of prolonged deceleration. The baby is beating at 140 beats. It has 1,400 circulations in 10 minutes. If it is beating at 60, 600 circulation. So it's missing 800 circulation in 10 minutes. So the lower the heart rate and greater the time, the more acidosis it will be. And if it is due to a transient factor like hyperstimulation, you can stop the oxytocin, give some terbutaline or put on a side, it'll recover fast. So you have to really, first thing as prolonged deceleration happens, you have to say, is it reversible or irreversible? Irreversible, like a scar rupture, abruption, cord collapse, then you have to intervene. And the final 2 points is about sinusoidal pattern, because I discussed about saltatory. This is sinusoidal. If it is acute bleeding, it is atypical. This is following fetal therapy of blood transfusion. The baby was bleeding and this happened. And this is a patient who had a fetal maternal transfusion for some time. So that is a smooth, regular sinusoidal. So the heart rate pattern physiologically can be, a pathophysiology can be affected by drugs, by temperature, by pressure on the head, by hypoxic events. It can increase, decrease, change in placental blood flow, fetal activity, all these can. So we have to interpret the trace based on, why do we think the baseline rate is up? Is it due to dehydration? Is it due to maternal pain? Is it due to infection? And if there is no deceleration when there is fetal tachycardia, then it has to be maternal temperature, infection, or pain because of the catecholamine surge and going into the baby. If there are decelerations, then it is likely a hypoxic element is getting. So that's the FIGO classification: 110, 161, 5 to 25. No repetitive decelerations, and interpretation, nothing to worry, no hypoxia acidosis. And suspicious mean one characteristic of normality is lost, and low probability of hypoxia and acidosis. Action is to correct. And if it is more than 1, less than 100, or severe pathological features like 100, less than 100, reduced variability or increased variability, sinusoidal pattern, then it's pathological. It doesn't mean you have to deliver, you have to assess the situation. Repetitive late or prolonged decelerations for more than 30 minutes or more than 20 minutes if variability is reduced, or prolonged deceleration more than 5 minutes. High probability of hypoxia and acidosis, so you have to take about immediate action. So FIGO classification produced in 2015 is fairly a good model, and it also has 3 tiers as mentioned at the introduction by Asmita: normal, suspicious, and pathological. And the basis is on pathophysiology, although there's a tendency to introduce pathophysiology as a different classification. Pathophysiology classification really talks about extension of the existing physiological interpretation of the CTG to talk about the rapidity of onset of acidosis. So I'm going to give some important points in interpretation, and I'm going to talk and link what we call as physiological definitions or physiological interpretation with the existing definition. So anyone who is going to do CTG interpretation must remember the baseline features are the ones which tells the baby is hypoxic or not acidotic. Those are accelerations and normal variability. These are the hallmarks. Somatic nervous system accelerations, autonomic nervous system variability. Accelerations with reduced variability should be considered suspicious, may not be of concern. So during the time 50 minutes of reduced variability, if you get sporadic acceleration, that's a good sign that the baby is not hypoxic. And also you must watch for deceleration during that 50 minutes. If there are no deceleration, that means the baby is not hypoxic. Periods of decreased variability may represent fetal sleep, but it's of little concern if reactive segments were seen prior to the episode and was no rise in the baseline rate and there were no deceleration. So emphasizing this point, no deceleration. That means hypoxia doesn't evolve without decelerations. Hypoxic fetuses may have a normal baseline rate, 110 to 160, no acceleration in the baseline variability less than 5 for more than 40 minutes. Then you have to think whether it's hypoxia, not very unusual. With baseline variability less than 5, repetitive shallow deceleration less than 15 are ominous. That's one of the traces I showed you, hardly any variability and shallow late deceleration. So clinical situation has to be examined, which is like thick meconium, infection, bleeding, absent fetal movement. Now, placental abruption, cord plugs, and cord rupture are sentinel events and can give rise to acute hypoxia, should be identified and dealt with clinically. Hypoxia and acidosis may develop faster with an abnormal trace in patients with the risk factors: thick meconium, growth restriction, intrauterine infection, pyrexia, pre or post term. So here, with a given trace, these babies will get acidotic 3 times faster compared to if the babies had clear like or well grown, no other problems. So time it takes to get acidosis is much greater if there's a high risk factor. And here is where we delay the intervention and the baby runs into trouble. In preterm babies, hypoxia and acidosis can predispose to hyaline membrane disease, RDS, and intraventricular hemorrhage. So therefore, if there's pathological trace, you intervene early in preterm. Injudicious use of epidural oxytocin, difficult deliveries can worsen hypoxia, which I mentioned on the risk factors. And during labor, if decelerations are absent, asphyxia is unlikely, but cannot be excluded. Now, I mentioned about intervention and the extension of the physiological definition by NICE, FIGO, or Swedish. So we had to think about hypoxemia, hypoxia, and asphyxia. Hypoxemia is lack of oxygen in the blood. Hypoxia, lack of oxygen in the tissue. As time goes on, the lack of oxygen in the tissue becomes combined with metabolic acidosis because anaerobic metabolism sets in, and that is called asphyxia. That is where we are more concerned as to what to do. So we'll look at long-standing hypoxia. The baby has tissue, lack of oxygen in the tissue, and those are very common in growth restriction, post-term thick meconium bleeding, infection, and so on. And that will look like slightly elevated baseline, but can be within the normal range, but shallow decelerations and hardly any variability. And this is a trace which I'm going to show you very quickly, hour by hour. There's no change except the shallow deceleration, and every contraction is going to increase the oxygen level, hypoxia, and build up acidosis. So it goes on like that, and then suddenly it collapses and delivered as a stillbirth. So in other words, long-standing hypoxia, the brain is blunted to some extent. It doesn't cause big decelerations. So you have to look for absent variability and shallow decelerations. The second, so here you can deliver the pre-existing hypoxia. If there is meconium, absent fetal movement, post-term bleeding, then you should deliver within 15-30 minutes. Gradually developing hypoxia is the one which shows the features, a rise in baseline rate, increase in depth and duration of the deceleration, and finally absent variability. And if it comes to that stage with absent variability, within 60 to 1 hour to 2 hours, the baby will be acidotic. So by the time it comes to, it started at 140, now it's about 180 and 170. And with absent variability, the depth and duration of the decelerations has increased, and the interdeceleration interval has become shorter. There you have to intervene. Acute hypoxia is where there is a drop in blood, the heart rate, and the acidosis builds up by 0.01. So in a gradually developing, it takes hours. So you can decide whether the heart rate is going to 140, 150, 160. And then once it becomes absent, you have to deliver that baby. Whereas in acute bradycardia, the acidosis builds up very quickly. And unless it is reversible, you should accomplish the delivery within 15 to 30 minutes. That's the example of acute bradycardia. This has been shown by some studies from our group in Singapore, published in 1985. So I was a young house officer or registrar when we published this about 40 years ago, about saying prolonged deceleration less than 80, 0.01, and we had to intervene early. And 25 years later, the University of Hong Kong published the same paper, similar, but with the larger numbers, and they also showed a drop of 0.011 in every minute. There's a drop, so therefore you have to intervene early. Now, the next type of hypoxia, so we have dealt with pre-existing or chronic hypoxia, the acute hypoxia, then we're talking about, I'm gradually developing, and we're talking about subacute hypoxia, where the deceleration lasts for longer time rather than the time interval between the deceleration. So 90 seconds, it might be decelerating in between 30 seconds. Here, the drop pH can drop by 0.01 every 2 minutes or 3 minutes. So you can say this is towards the end of the first stage, and there must be occult cord compression. The duration is lasting more than 90 seconds. The interval between deceleration is 30 seconds or less. Saltatory pattern, the pH is going to drop 0.01. So this is every 10 minutes. We are going to show you the slide, and say 20 minutes, pH would have dropped by 10, and there's saltatory variability as well for the acute nature of hypoxia. 40 minutes, 60 minutes, it becomes bradycardia. So in 60 minutes, the pH would have dropped by 30 points, and once it is bradycardia, 10 points in 10 minutes. So 40 points it would have dropped in this case. So the pH here is 6.79 or 6.8. So at the beginning, when deceleration started, it must have been 7.20. So there are plenty of time to deliver, and above 7 is okay. So calculating from the type pattern, within 30 minutes, you should deliver this baby. Otherwise, baby will have cortical damage, bilateral cortical damage, and spastic quadriplegia. And the acute bradycardia would cause thalamic hypothalamic damage and athetite type of cerebral palsy. Now, this is connecting the types of CTG to the types of injury seen, and that came through in 1970 by Myers, who did some monkey experiments and showed if there is total asphyxia, like prolonged deceleration, then the brainstem and thalamus gets damaged, and that scarring will be there for life, and that will cause athetite or dyskinetic type. If it's prolonged hypoxia with acidosis. This is we call prolonged partial hypoxia, intermittent compression of the cord. Then it is bilateral cortical necrosis, motor cortex get affected, and that comes with quadriplegia. But if it is without acidosis, there might be some white matter damage. And total asphyxia, which is acute profound, then mixed acidosis causes both damage to the cortex and the basal ganglia. And the CTGs can be correlated. And the brain pictures, I'll bring it back to the same slide I showed you. And there have been studies which shows that if the baby has antepartum or early intrapartum risk factors, and then goes into labor and the CTG is ignored, it has a high chance of running into trouble of acute bradycardia. Here, the thalamic hypothalamic area is damaged and the baby comes with athetide or dyskinetic type. If it is prolonged partial hypoxia, prolonged partial from time to time, then bilateral cortical necrosis, the fibrous tissue remains, and they will come with quadriplegia. And Henry Hackberg, who was one of the good obstetricians and combined neurologists from Gothenburg, did neuroimaging, MRI, and he showed in 81% of the babies born at term, either they showed the bilateral cortical atrophy or thalamic hypothalamic injury, suggesting that it happened in labor and not before or after that. Now, preterm babies have a different pattern of brain damage. They usually present with hemiplegia because the mechanism when there is an asphyxia is to get periventricular hemorrhage, and then becomes periventricular leukemia. So this is in a preterm baby, not in a fetus. When there was a preterm baby has severe hyaline membrane disease and oxygen levels are not maintained, it initially starts with the cerebral periventricular bleed, and then the blood clots get absorbed. And when the ventricles, the vacuoles are indicating it's getting absorbed, so there's space created, and the space created is occupied by the ventricles, and the ventricles dilate, and as a result, the corticospinal tract gets compressed. So the hemiplegia on the opposite side because of the crossing. If both ventricles expand, then there will be quadriplegia. So unfortunately, the obstetricians have very little tool to play with. We go for cord blood gases, and we look for encephalopathy beyond 34 weeks. And by 18 months, any baby which is asphyxiated will show signs of cerebral palsy. By 18 months, if it doesn't show, that means the baby didn't get any insult. And the insult is usually quadriplegia or dyskinetic type. And by 18 months, some babies get epilepsy. About 17% of severely asphyxiated will get epilepsy. So that's also an added thing. Now, of course, the cerebral palsy, spastic quadriplegia or dyskinetic type, we had to take for 18 months, but early scanning of the brain, if it shows edema, then that's a problem, and we had to think about that. Of course, you had to rule out other factors which can cause cerebral palsy before we come to that conclusion. So this is imaging ultrasound scan. Soon after, in the neonatal intensive care, the ventricles are obliterated and it is hyperechoic. This is after the baby had died. You can see postmortem shows edema to the brain. So early evidence can indicate there's going to be a problem by 18 months. So in concluding, we can improve performance by better understanding and interpretation. And important is timely action. If attention is paid to pre-existing risk factors, if the iatrogenic risk factors that increase field compromise are recognized, like preterm, postterm bleeding, thick meconium, growth restriction, infection, CTG is interpreted better by considering the pathophysiology that cause CTG changes. Knowing when and how quickly to intervene based on the concept of acute, subacute, gradually developing, and pre-existing hypoxia patterns are important. That some have taken that chunk out and called physiological CTG interpretation, but it's the same. Even the nice one and the figure one is physiological based, but what the small group calls it as physiological interpretation is really an extension of the existing system to indicate the rate of building up of acidosis and when to intervene. So better communication and multidisciplinary team care by the midwife, obstetrician, and neonatal pediatrician is important. So I'd like to conclude with this particular slide just to show that process of labor is like a baby swimming from one end of the pool to the other end. And it is inevitable the baby has to go number of times underwater and come up. And if, for example, if you try to dump this baby too many times, the baby is going to get hypoxic and run into trouble. And some babies, their physiological reserve is not so much. So you might sometimes, if she's on oxytocin and too many deceleration, you can stop it, give termutaline, and take the baby out inside of the pool and then put the baby back. It'll swim again. So as long as progress of labor is there, you can deliver many of the babies without asphyxia, unless there is a catastrophic sentinel event. So go slow, don't augment early, use an infusion pump if there is oxytocin. Observe the trace very carefully and see whether you can alleviate by positioning and stopping oxytocin and seeing how best to manage. Because baby will finally swim, and we are restless because we want to go for golf or tennis. So we try to push the oxytocin and deliver the baby early with an abnormal trace. But we don't have to in many cases. Thank you.
Thank you.
Anita, your comments.
Thank you very much. What can one say after Sir has given this very extensive lecture? I do think it's good that we can go over it over and over again, because physiology, no matter how much you sort of learn it, you still need to remind yourself. And I have to admit that the paper that you talked about, the vagotomy, and looking at all the changes, I think I'll have to go over that again, because it's difficult to absorb everything in the first hearing. So I do definitely think that, we're very fortunate to have MedTalks and Dr. Sharda Smith get this together, because I really think that for the viewers also to go over and over again, the sort of fundamentals that you taught is really important. I wish that, and I hope, Dr. Sharda, you can take that on, that we make these short CTG not classes, but little workshops where you sort of do it and learn from it over and over again. And these things about communication, I think that's really important. From my point of view, sort of fetal medicine, we deal with a lot of antenatal CTGs, to be honest, rather than intrapartum. So I was just wondering, because we base our deliveries on the sort of truffle trial and the results of that. And we've used the basic CTG as our guide. Do you think that the computerized is where we should push, or whatever we've been doing till date, because that's the most practical and that's the most convenient, is good enough? I mean, what are your views?
Yeah, I think I would like to. I mean, you're the specialist, Anita. I'm not the specialist in fetal medicine. But coming to the point is, actually, I have lectured with Christoph Lee and Redmond and others, and the initial CTG was sent to me by Jeffrey Dawes' formulas of calculation. So we worked with that in Singapore, and it is very useful for preterm, like the truffle study, because at the preterm there is some small changes, like a deflection of the baseline change will cause something like a deceleration less than 15 seconds. The variability is reduced and the baseline heart rate is slightly tachycardic. But I think once you cross that limit of 28, 34, then the Doppler umbilical cerebral blood flow takes over the changes. CTG gives an added value because CTG talks about the brain. So if you take a cascade and look at growth restriction as a point, then as time goes on with more hypoxia, there's a redistribution of blood flow, like what you normally do as fetal medicine experts. Umbilical artery, peripheral, the pulsatility index goes up, and then as further comes on, then there's slight reduction in like a volume. Then there's a brain sparing effect of increase in middle cerebral artery, and the CT changes are right at the end. Because even if you give little blood to the brain, the CTG will be normal, and then it will suddenly drop. So if you want to do a comparative studies, then at George's at least, we do umbilical artery flows till it becomes into a critical point. Then we add CTG as subsequently. And so if it is prolonged pregnancy, we just do like a volume and CTG, because we take that because the flows don't very much. But 34 to 37, we highly depend on the Dopplers. And under 34 weeks, we add the CTG with computer translation, because that seems to give some information. But we have the Doppler as well, so we don't, I mean, when an adult comes with an illness, we do the blood pressure, pulse, ECG,
So we should.
even electrolytes. And for the baby, why should we not give the benefit of doing Doppler and CTGs, whatever we can?
Yeah, no, I agree.
Asmita, your last comments, concluding remarks.
You're on mute, Asmita.
Unmute yourself.
Yeah. Prof, just one small query. The CTG has a very high false positive rate. But when we talk in terms of an adjunctive test, I think in a country like India, we have a very few options, because fetal skull blood sampling is practically non existent even in best of the setups. So, what would be your suggestion in such a situation? Should we keep on doing cesareans with our abnormal CTGs or use something else?
Yeah, so with the number one is to improve the CTG interpretation, because what we think as decelerated trace may not be of worry if the baseline is steady, and if the baseline variability is normal and the deceleration intervals don't increase. So I think one is that. Second is actually you can use some physical stimulus, which has been shown to be of usefulness. And in Singapore, we used to use a lot of vibroacoustic stimulus, like an electronic larynx, and used in ENT. We used to keep it near the baby's head and then make a buzzing noise, and it accelerates. And Deirdre Murphy from Ireland has done some studies recently, not very long ago, just a couple of years ago, of skull stimulation with the finger. Now, I did some studies 25 years ago using Alice tissue faucet, putting it and pinching the baby, but that's traumatic. But Deirdre Murphy's one, which she just puts the finger and then doesn't press, but just keeps on moving, and then it shows acceleration. That means the baby is not acidotic. But you have to do that when there is no stress on the baby. That means if there's any oxytocin, you have to stop that and wait and see whether it improves. If it improves, fine, but otherwise you can use that. But when it comes to that stage, then you need a senior person to be involved to look at the parity, the rate of cervical dilatation, the risk factors, and so on. Because as we all know, that in a given trace in a nulliparous woman at 3 centimeter, we might do a section, but given the same trace at multiparous at 8 or 9, we'll just wait, because she's going to deliver within a short time. So I think it's complex mathematics. It worked better with a computer here, and that computer works better with old age. So I think it's a teaching. I think for the question you raised is raise the standards of people to interpret the CTG with clinical risk factors, like the Royal College studies shows. You have to identify risk factors. And then if you want to add further to that, you can add as adjunct, like a vibroacoustic stimulator.
Dr. Anita, we will not be able to take up questions, but this recording will be available for everyone to go through it time and again. And in the end, you have to give a concluding remark and thanks to Professor Anita.
Well, all of us in India are such big fans of Professor Aral Kumar, and we look forward to seeing him. I had an opportunity when he had a backache, and despite his back, how is your back, Professor? Now, hopefully fine. He still did our workshop when he'd come to Delhi for that. So I have tremendous admiration for you and a lot of respect, and really we are so grateful and thankful for you to keep interacting with us, and really warm regards from all of us to you. So We look
Thank you.
forward.
Thank you very much. Thank you.
We're just
Thank you.
happy Navratras. Okay. Good night. Thank you, Dr. Sharda, Dr. Asmita.
Thank you
Very
very much.
nice.
Thank you.
Thank you.
And of course, for us from TED Talks. So
Thank
thank you.
you. Yes.
Good night, everyone.
Good
Bye.
night.
Thank you, ma'am. Thank you so much for a wonderful webinar.